I'm Dr. Vijay Neglur, consultant diabetologist from Thane. Extend a warm welcome to episode 4 of 4D, which means detailed discussion and dialogue for patients of diabetes. And today we will discuss about the involvement of the kidney in patients of diabetes. We know 30 to 40% of the patient in the lifetime of disease develop kidney disease, and therefore it's very important to realize that kidney impairment is one of the important comorbid conditions in patients of diabetes. And what's important is that 94% of the death have increased because of kidney disease since 2012. So that is a huge impact of the kidney disease that we see in patients with diabetes. Now, to discuss this in great details, we have very talented speaker, Dr. Neeraj Manikat, who is the assistant professor of nephrology from the Government Medical College at Kozhikode. He did his undergraduation and post-graduation education from Government Medical College, Kozhikode, and he has been a principal investigator for many clinical trials, both in India and abroad. With the brief introduction of Dr. Neeraj, may I request Dr. Neeraj to present his deliberation on the diabetic kidney disease in patients of diabetes. Over to you, Dr. Neelkant.
Thank you, Dr. Vijay Naglu, for those kind words of introduction. And it's indeed a pleasure to talk with you as a host. Thank you once again. Can we have the slides, please? So the topic would be diabetic and chronic kidney disease. At the onset, I would like to say that people with diabetics don't die due to diabetics usually. They don't die due to high blood sugars, except very rarely in diabetic ketoacidosis or hyperosmolar coma. Most of the time, they die due to chronic complications of diabetic, which are part and parcel of improperly treated diabetics or under-evaluated diabetics, I would like to say. So my stress would be on diabetic and chronic kidney disease. If you look at the extent of diabetics and the comorbidities, we can see. Next slide, please. This is the extent of diabetics in India. The prevalence of diabetics in India is something around 10% in an adult population, 20 plus population. And the number of people with diabetics is the second largest in the world. So we can see that the onus is on treating physicians to diagnose diabetic, to properly treat diabetic. When people have diabetics, it's just like hypertension, that the treatment targets, more than 50% of the people don't achieve their treatment targets. That means that the recommended treatment targets are not attained, means they are at risk of running to diabetic complications. So it's just like the tip of the iceberg which hit the Titanic. The Indian diabetic is an iceberg where we are seeing apparently only a few people who are diagnosed to be diabetic. Much more are there yet to be diagnosed to be diabetic. And even in people who are diagnosed to be diabetic, 50% have not achieved target. And this is not a very dismal figure. The figures are dismal, but world over, this is the case, and we need to improve on our focus on controlling diabetics effectively and diagnosing more cases out of the people who are walking in the streets with diabetics and not knowing they are diabetics. So it's just like a ticking bomb in there. And when we look at the burden of chronic kidney disease, the first thing that comes to a physician's mind is that chronic kidney diseases are due to glomerular diseases. But when you look at the proportion of people who have chronic kidney disease and the underlying etiology, we can see that primary glomerular disease just accounts to less than 10% or something like 7%. The rest, major chunk, is by diabetes. 44% of chronic kidney disease burden is by diabetics, which is a preventable disease. Preventable disease, when you diagnose diabetic early, treat diabetics effectively with personalized medications, looking at the risk factors for the individual, target him. And the second contributor is uncontrolled hypertension, which again, I would say it's not just pure hypertension. It may be a significant contribution, maybe diabetics along with hypertension in that. So together they contribute more than 70%. That is 3/4 of chronic kidney disease who are facing dialysis or on medical management of diabetic or medical management of chronic kidney disease are actually preventable. We know that primary glomerular disease are not preventable entities. Diabetic kidney disease is a preventable entity, or at least an entity that can be managed effectively and prevented from going for chronic kidney damage. We all know the various pathophysiologies involved in the progression of uncontrolled hyperglycemia to diabetic nephropathy. So immaterial of whatever the pathogenesis happen, it is the proper control and prompt control of diabetics, not only the sugars, but also on the molecules that are characterized by better protection, renal protection. Because 10 to 20 years back, we hardly had any molecule other than insulin, metformin, and sulfonylurea. Now there are a plethora of compounds, pleiotropic effects, which show that beyond diabetic control, there are additional renoprotective, there are additional cardioprotective effects. So it's a time, and most of these compounds have come off patent and is available to the vast majority of the Indian population at a cheap cost. So it's a time that we embrace these medical treatments, start treating our patients not beyond the blood sugar values, to look at the pleiotropic effects these molecules provide and utilize them in our armamentarium in the treatment of diabetes. So together, we would like to say that CKD still is a preventable illness. When we look, 70% of CKD is due to improperly treated hypertension, improperly treated diabetes. So proper treatment can definitely delay a vast chunk of these patients from developing CKD and becoming dialysis bound. And when we look at the kidney disease, in diabetic kidney disease, it's a progressive loss of renal function. So just like most of heart failure, once it sets in, it is a progressive, reversible, or partially reversible, or retardable progression to renal failure. So be it due to kidney damage, pathological abnormalities, or EGFR decrease, ultimately, chronic kidney disease is something that has to be prevented. So progressive renal function is what has to be arrested or reversed at any stage of diagnosis of a kidney disease in a patient. And this is the classification and the screening criteria for diagnosing CKD, managing CKD. So you have a huge population of patients with diabetes coming to your OPD. How do you know which patient has what degree of renal affection? So basically, when do you screen a patient for renal affection? If it is a type 1 diabetics, right at the diagnosis, we are supposed to screen the patient for diabetic kidney disease. When it is a type 2 diabetic, probably we should screen them every 5 years after the diagnosis and then subsequently yearly. So the first 5 years in a type 1 diabetics is okay. You can wait. In type 2 diabetics, you should start screening right from the diagnosis and every yearly after that. Now, how do you do that? It's pretty simple. You can do a spot urine albumin creatinine ratio, which is fairly very simple, easily available, slightly costly, but make the spot albumin creatinine ratio makes the patient very comfortable. He doesn't have to collect the 24-hour urine sample and bring it to that. Also, along with that, you can calculate an EGFR using the several formulas that are available and available in apps. So always, when your patient comes to you as an index case of diabetic, make sure you do a spot urine albumin creatinine ratio along with an EGFR if it is a type 2 diabetic. Immediately calculate the EGFR and note it in your case records, because this is needed for future reference to see whether the patient is deteriorating, remaining status quo. Now, what does a positive result mean? Now, a positive result at the first screening for a urine albumin creatinine ratio doesn't mean he has severe nephropathy, because there are a lot of confounding factors like urinary tract infection, drugs, and a lot of things that can produce a false positive urine albumin creatinine ratio. So a single value doesn't mean anything. Always recheck the value after 3 to 4 months. And if it is persistently elevated, then you should start the patient saying it's a patient having diabetics with a diabetic nephropathy. And then there are, once you have picked up a nephropathy or a severe nephropathy, then it's high time you should go aggressively, reverse the risk factors that are progressing the nephropathy, and target drugs that are known to retard the progression of nephropathy. Now, basically, this is a very useful tool where you go by the CORS, GFR, and albuminuria criteria, the GA criteria where we use. And this table elegantly shows at what point of time you should refer the patient. The red things are always refer the patient and treat the patient because he's at a higher risk of progression to end-stage renal disease needing hemodialysis support. While the green ones, screening can be continued. The yellow ones are the relatively threatening ones, but keep the patient under follow-up, treat the patient aggressively. So as a physician, the green, the yellow, and the orange ones are the ones that they can treat. But once the patient is gone, transgressed to the stage of red, probably he needs the assistance of a nephrologist in the management. So this is an elegant chart that shows at what point of time the one on the x-axis is depending on the quantity of albuminuria. When it is below 30 milligram percentage, he has no nephropathy. It is 30 to 300, he has moderate proteinuria, albuminuria, and more than 300, he has overt proteinuria. And the other thing is based on the EGFR actually. So what are the therapeutic strategies in diabetic management that has got an implication on renal involvement? Now, 3 classes of drugs have definitely shown that they have got renal benefits, and they are DPP4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor antagonists by varying mechanisms, of which DPP4 is the utmost thing that has shown evidence in nephropathy not only diabetic nephropathy, even in non-diabetic nephropathy, they are being increasingly prescribed. So also in cardiovascular disease, non-diabetic, even in non-diabetic heart failure, they are being increasingly good. Sorry, SGLT2 inhibitors. SGLT2 inhibitors like canagliflozin, DAPA, and MBAR increasingly recognized as to be having severe renoprotective effects beyond diabetic. Even in a non-diabetic, now they are being advocated. So obviously, there are benefits in a diabetic with kidney disease. So also if a diabetic is having coronary disease. And DP4 inhibitors like Sicta, Saxa, Lina, and Algo has got certain unique properties that make them good in the management of a patient with diabetic with kidney disease. So does GLP-1 receptor antagonists. We'll come to that briefly. And if combination of these things, now from 2022, there has been increased recognition on personalized treatment of diabetics rather than one treatment for all patients with hyperglycemia. It's not like that. You should individualize the treatment. Some people have got increased risk of renal disease. Some people have got increased risk of cardiovascular disease. Some people are just obese with diabetics. Some people are just lean with diabetics. So a single treatment for all these doesn't suit. So you've got to see 8 to 9 classes of compounds with different pleiotropic effects that are now available, which you can utilize, use in combination. At the same time, try to preserve the beta cell function till the late stages and use that in the elegant treatment of diabetes. So fixed drug combinations are increasingly become popular as a start on drug treatment, the first drug treatment, and metformin is no longer a must as the first line treatment, provided there are adequate reasons to say that a DP4 inhibitor or a SGLT2 inhibitor is preferred in these patients. So DAPA with combination, SGLT2 inhibitor in combination with the sitagliptin-like molecule has got very much action on different parameters, including glycemic control and the persistence of glycemic control, and of course the durability of action as well. So basically how they act in synergistic manner. SGLT2 inhibitors, we all know that increase the urine glucose excretion and decrease the plasma volume, and it preserves, and by producing glycosuria, it will increase the beta cell insulin sensitivity and increase insulin resistance. At the same time, endogenous glucose and glucagon secretion is increased. Similarly, along with these changes produce decrease the cardiovascular risk, decrease the body weight, decrease the uric acid, decrease the systolic blood pressure, and decrease the body weight effectively, which are very good, very good as far as obese diabetes is concerned. The other arm, DP4 inhibitors will decrease the endogenous glucose and glucagon production. At the same time, it will increase the insulin secretion and the incretin effect, and definitely that has got a benefit in lowering blood sugar. And a combination of these two things have shown overridden the concerns of possible increased urinary tract infections as well, which was a concern with SGLT2 inhibitors. So together these two, they make a very good combination in the management of type 2 diabetics and people who are at risk of renal disease. The SGLT2 inhibitors has got a non-insulin dependent effect, so it can be used at any time in the management of type 2, be it early type 2 diabetic where the patient is not insulinopenic, or very late in diabetic where he is insulinopenic. That's an okay drug in all these drugs. The only problem of giving an SGLT2 inhibitor if the patient is having severe ESRD and the GFR is very less, because it doesn't act in those patients, because renal mechanism and urine excretion is needed for the action of SGLT2 inhibitor. So there are various trials that have shown the benefit of SGLT2 inhibitor. You don't need a trial to show aspirin's effectiveness, and something similar in SGLT2 inhibitor. As far as renal endpoints are concerned, all the trials, DAPA CKD, DECLARE, TIMI, DAPA heart failure, they have all shown the elegant benefits of SGLT2 inhibitors, more so in DAPA and also in other SGLT2 inhibitors as well, in preventing the progression of the renal disease, preventing the progression of heart failure, in decreasing mortality. So there are the various mechanisms explain this, and real world data has shown that they are extremely useful. So this slide shows the dose adjustment that are needed and CKD. As I told, SGLT2 inhibitors has got an action via kidney. So in patients having profound renal failure, stage 4 kidney disease, you may have to decrease the dose or stop the dose. And as far as DP4 inhibitors, you have to decrease the dose. So when we look at the GFR, you can see DAPA is standardly given in the dose of 10 milligram per daily. You can give sitagliptin 50 milligram per day if the eGFR is above 60. In patients who are severely decreased eGFR of less than 25, you can probably skip the DAPA, continue with a Sita of a lower dose of 25 milligram per day. So that's the only concern. At what point of time you should not initiate a patient on a DP4 inhibitor and decrease the dose of SGLT2 inhibitor, or at what point of time you should stop or decrease the dose of SGLT2 inhibitors in a patient who is already already receiving treatment with CKD. So altogether, at the end of this thing, I want to say that beyond glycemic sugar, just sugar values and targeting the ADA of less than 110 and less than 140 or 150 post-prandial sugar, we should be having a holistic approach for patients with diabetics. Diet, exercise, lifestyle, quitting smoking, quitting alcohol is a must for all patients with diabetics. Along with that, depending on the patient's comorbidities, you can choose the first line to be a SGLT2 inhibitor if he has a renal involvement or is at high risk of renal involvement. Again, metformin if he has no other contraindication for metformin. And then depending on the associated hypertension, you can choose a RAS inhibitor if he is having severe hypertension. But ultimately, what I want to say is that beyond looking at the sugar values and targeting oral hypoglycemic drugs and sulfonylureas, a balanced approach at looking at the comorbidities and the possibility of this patient developing end organ damage would be highly effective. And always screen the patient for EGFR right from the first presentation by using a urine albumin creatinine ratio and an EGFR formula, which are widely available, and you can use it in your mobile. Just know the height and weight of the patient and age of the patient. You can apply that formula and get a creatinine value, and you can get the EGFR. Quote that for future reference because that will be extremely useful for you to see when the patient has gone years later when the patient develop some comorbidities.
Yeah, thank you, Dr. Neeraj, for an
Thank
excellent
you.
overview on diabetic kidney disease. There are a few questions that have come up because of the interest that you presented in your discussion. And the first question is, what are the early signs and symptoms of DKD?
Yeah. As far as kidney disease is concerned, it's a silent killer, just like hypertension. So probably you have to be very, very, very sensitive in asking the questions because nocturia is an early sign of kidney disease. But in a diabetic, nocturia is a treacherous sign because uncontrolled blood sugars can have nocturia. People having lower urinary tract symptoms and benign prostatic hypertension can have nocturia. So whenever a patient says of nocturia or your question of nocturia comes as yes, always ask him about the volume of the urine that is passed. So if he has a reasonably controlled blood sugar and an A1C and he's passing a lot of urine in the night, that is definitely pathological nocturia as far as possible marker of CKD. But when the patient has an uncontrolled blood sugar and he has a polyuria and nocturia is part of that, probably it's not just that sensitive to pick up a kidney disease. Then the third one would be patients having lower urinary tract symptoms like prostatic hyperplasia in the male elderly with a nocturia symptom. Again, they won't have large quantity nocturia. They have increased urinary nocturnal awakenings and nocturia, but the volume won't be so huge. So ultimately, it's the volume and the ratio of the volume that they pass in the day to the night that is important to pick up nocturia. But also other symptoms are equally important. In Kerala, what we find is that early signs of renal failure, most of the people hate to have the smell of boiling rice. They just the kanji being boiled, they feel nauseating at that time. By that time, when we look at the creatinine, they would have a creatinine that's around 2, 3, 4. So depending on the regions, they may have specific things. But what we find usually is that do you find kanji revolting? Yeah, that's probably an early sign that you are developing some form of renal dysfunction. Again, urine albumin creatinine ratio has its own problems because of slightly costly investigation. But again, it's possible to do. Don't rely on urine dipstick test alone to rule out a renal disease because they are treacherously negative in most of the cases. And you do a urine ACR, they may have very high values.
Yeah, I think you're right. Most of these patients are asymptomatic for a long period of time. They can come with vague symptoms like fatigue, anorexia, as you mentioned, and swelling of the feet are some of these symptoms that come up. As the patient gets complicated, for example, he gets anorexia further, encephalopathy, will have nausea, vomiting, ageugesia, loss of taste is also important. And of course, these patients can have complications of microvascular like retinopathy and neuropathy, which can coexist with this. Those symptoms can also occur in these patients. And science-wise, of course, you get hypertension, you get edema in these patients, and you have the complication like retinopathy, or you can get proteinuria in these patients. As you mentioned rightly, anybody has persistent proteinuria and decreasing GFR, and with evidence of retinopathy, we diagnose them as a diabetic kidney disease. So well said, well answered. The next question for you, Dr. Neeraj, is that how can the diabetes management help to prevent or slow down the progression of chronic kidney disease? How will you slow it down? What are the methods that you adopt
I think the first and foremost, as we all know, is the tight control of diabetics and tight continuous control of diabetics, achieving the A1C targets are the prime importance. So beyond that, we have now certain molecules that are available which are known to preserve the renal function. Like SGLT2 inhibitors are known to preserve or retard the progression of renal failure. So whenever possible, when a patient is having an overt renal failure or an incipient renal failure, we shouldn't hesitate to control his blood sugar tightly. Along with that, to initiate these class of compounds, which have shown multiple studies have shown that they do retard the progression to end-stage renal disease and dialysis dependence. So most of these drugs, SGLT2 inhibitors and DPP4 inhibitors, should be initiated when you have a patient at hand who is having some form of renal involvement, be it uncontrolled hypertension with proteinuria or albuminuria with a diabetic status. We shouldn't hesitate and just go back to our routine management of diabetes. We should initiate these drugs at the earliest.
Yeah, I think you're right. The standard of care is important, like management of hypertension, the glycemia, and of course, diabetes and blood pressure. They are important. ACE and ARB are also very important. Then SGLT2 and finerenone are also to be added in a sequential manner. So as early as possible, if you can get these drugs on board, you can prevent the decline of GFR significantly, so much so that you can prevent or delay the dialysis to the tune of 15 years. So therefore, that's the beauty of adding therapy sequentially so that you can delay decline of GFR in these patients. You rightly mentioned about the combination therapy of SGLT2 and DPP4 inhibitor as the one of the best combination to treat patients of chronic kidney disease and diabetes. Can you tell us what are the populations, special populations, which will benefit from this combination?
Okay, I think people who are overweight definitely would definitely benefit from this because
Yes.
of the weight neutrality of weight reduction of SGLT2 and weight neutrality of gliptins. They are very useful probably in this patient because ultimately weight is an independent factor for the progression of renal disease. So does uncontrolled diabetes. So controlling the weight definitely will go a long way in controlling diabetics and also in progression of renal disease. Then probably people who have baseline higher elevated renal parameters, who are having other comorbidities like hypertension, coronary disease, who are at a higher chance of progression to renal failure. Probably comorbidities and the physics of the patient would be what makes me think in terms of prescribing these medications.
Yeah, I think those who are intolerant to metformin with the A1C of 8.5% will definitely need this molecule. Concomitant heart failure and established cardiovascular disease, again, you will use this molecule. Prevention of dialysis, at least by 15 years in patients of chronic kidney disease, will be useful. Obesity, as you rightly mentioned, and even non-diabetic kidney disease also. Now this, I mean, the
Yeah.
only SGLT2 can be used in these patients. That's great. Now you said about the screening of these patients. You mentioned that what are the tests that you will use to screen patients with chronic kidney disease and why it's important to screen these patients?
So I think basically, although urine routine examination has its own fraught with some problems, I would still do a urine routine and urine albumin creatinine ratio in all patients with diagnosed type 2 diabetes at the time of diagnosis. And in type 1 diabetes, as I told, after 5 years of diagnosis. This importance is that because a routine examination can pick up glomerulonephritis, which may be a primary glomerulonephritis as well. And urine albumin creatinine ratio is needed to quantify the amount of proteinuria, albuminuria in these patients. So I try to do a urine routine examination which is cheap and easily available. And if I find some sediments caused in that, my doubts will be in terms of a primary glomerular disease. While if they are bland at the same time your patient has urine albumin excretion ratio that is above 30, I would think of a primary glomerular disease. Secondary glomerular disease as part of a diabetics. Which case I would be targeting more diabetic control and drugs that would prevent the progression. While in the first case, I would target for a primary glomerular disease, which can very well coexist with a patient having diabetics as well.
You're right. If you see the statistics, it is less than 40% of patients get the recommended testing. It's very surprising to see that. Even the good centers, only less than 40%, 60% of patients are not managed, not screened at all. And therefore, simple as you mentioned, the spot urine test, what's called urine albumin creatinine ratio is important, and it should be done at least for 2 to 3 samples, stretched over 3 to 6 months. You can't jump to conclusion with just one sample. So you need to repeat it again. And of course, you can calculate EGFR with almost all these smartphones. You can just key
Yeah.
in those parameters and you get the EGFR very easily. But important is to repeat them annually. That's how you can pick them up because large number of patients are asymptomatic or they have vague symptoms, and therefore it is very easy to miss kidney disease, and therefore screening is of paramount importance. Otherwise, the patient will come to an advanced stage where most of the possibilities of giving them treatment are already lost. Okay, we talked so much about the SGLT2 as a molecule, which we've been using for patients with diabetes and even without diabetes. Can you just enumerate what are the renal benefits that we get with the SGLT2 and what are the possible mechanisms that are there which gives so much of benefit to these patients of diabetic kidney disease or even in non-diabetic kidney disease?
I think SGLT2 basically change the renal threshold of glucose excretion. So in a diabetic, in an uncontrolled diabetic, the renal threshold is fixed at a higher level. So the moment it is refixed at the normal physiological level, the patient start excreting glucose in the urine, and that amounts to loss of calories. And that loss of calories, along with the osmotic diuresis that it precipitate along with that, the drag of water that it makes help the patient become more insulin sensitive, less insulin resistant, a better control of blood pressure, and of course, loss of calories would entitle him to lose body weight as well. So these are the good effects of SGLT2 inhibitors that we observe. The only problem practically when you start an SGLT2 inhibitor in a type 2 diabetic with a creatinine value slightly high is that there is an initial phase of slight creatinine elevation, which shouldn't produce a panic in you or the patient. It's reassure the patient. That's the mechanism of action of this drug, and that is fairly commonly and well documented, and you will stabilize after some time. So most of the time, when we see people starting on SGLT2 inhibitors, the moment the creatinine goes by a zero point 0.2 or a 0.3, that's immediately stopped and discontinued. But that needn't be done actually. You can always wait for that, and usually that plateaus over a few weeks, and then no longer progression is there, and then the long-term benefits would come to the patient.
I think you're right. What you mentioned is a tubuloglobular feedback mechanism, which brings into interaction, and therefore what happens is a constriction of the afferent arteriole, and that reduces the EGFR initially, but that is protecting the nephron because it protects it from a barotrauma, and therefore that is the most important action. Furthermore, it does reduce the indulging in natriuresis, therefore it brings down the blood pressure. It also reduces a lot of inflammatory markers, especially NF-kappa B, and that also reduces inflammation. We know that the inflammation is a major driver for the renal impairment in patients of kidney disease. And all these inflammatory markers like NF-kappa B, interleukin 6, and the macrophage attraction into the tubules are all prevented in patients with kidney disease, and therefore they get the benefit. And finally, the super fuel theory that you know of is the beta hydroxybutyric acid, which becomes a super fuel. It's as good as glucose because if you give one atom of oxygen, gives you roughly about 3 ATPs with the beta hydroxybutyric, and it is much better than free fatty acid, which is a dirty fuel. And therefore, this is again a very important aspect in preventing the damage to the kidney. And of course, we talk about the NLRP3, the Nodlag receptor 3, which is also an inflammasome, so reduction of inflammation is important. And of course, the hydroxyl carboxylic acid receptor activation is also important to bring about deacetylation, histone deacetylation, which also reduces inflammation and lipolysis. And therefore, these are all the various facets of the drug which brings so much of benefit to the patients of kidney disease with diabetes. And therefore, the earlier you use this molecule, it is better to these patients and not to wait too long. As you mentioned rightly in your talk, you did mention, you did emphasize this, that the early use of SGLT2 and of course DPP4 combination will definitely take patients to a long way and has a good healthy life, and patient will bless you for having treated properly. So Neeraj, before we part or we close this discussion, I would like you to say a one-line message to all the doctors who are listening to your talk, on the pearls of wisdom so far as diabetic kidney disease is concerned. What would you say to them?
I think diabetic kidney disease is something that is a preventable illness in all patients with diabetic, and it's a potential complication that can occur in all your patients with diabetes. So be vigilant. You check the blood pressure, you check the sugars, you check the food, but never forget to check the renal function, especially not the creatinine alone. Look at the GFR, look at the urine album creatinine ratio. Don't hesitate in that. Never diagnose a diabetic kidney disease after the creatinine gets elevated. It should be months and years before that. A routine screening of urine album creatinine ratio and urine routine, and of course, symptom analysis of this patient. Thank you, sir.
Right, that's why Dr. Neeraj you said screen these patients. Look at the urinary protein, look at the creatinine, look at the GFR, and treat them aggressively as early as possible so the patient's kidneys are protected. Thank you very much for your fantastic
Thank you, sir.
advice, Dr. Neeraj, and we really enjoyed listening to you. And hope everyone who's tuned in also had enjoyed listening to you. Thank you very much.